And here, by my side, we have Dr. Carlos Abad, the medical head of Interventionist Radiology Department of Hospital Português. So welcome. It's a pleasure to be here, Karina. How was your trip? Well, a little bit tired due to the pandemics, but everything went fine. So you will be a moderator of a very important debate, isn't that? Yes, we will have a very good debate, high-level debate, and I'm honored and happy to have here friends and professionals that represent the elite of interventionist radiology in Brazil and South America. And for a little more expectation, we have, before the debate, an international attraction, and the audience is really willing to see it. So I invite Dr. Abad and everybody that is here to have this 20-minute lecture. Of course, we visited Julien Garnon at his service, and he promoted the buy of this equipment. It will be very nice for our meeting. So today, the lecture has Dr. Julien Garnon, member of Interventionist Radiology Department of the Hospital University of Strasbourg in France.
Good evening, I'm Dr. Julien Garnon. I'm very happy and honored to celebrate with you today the installation of the first Canon Angio-CT device in Brazil. So during the next 15 minutes, I'm going to share with you my experience using this equipment in interventional oncology. First of all, just to explain a little bit more about myself, I work and live in Strasbourg, a very lovely city at the eastern part of France. I hope you will have the chance to visit us one day. And in the hospital I'm working in, I have the chance to have access to a department which is fully dedicated to interventional radiology. So we can perform procedures under MR, cone beam, and angio-CT guidance depending on the case. Of course, today we are looking at the angio-CT device and see how you can increase the number of treatment and the type of procedures in the very next future. So this is the angio-CT. So it's a combination of a CT scan mounted on rails, a cone beam mounted on the seal, and of course you can add an ultrasound within the room whenever necessary. So the key message of today is it's all about multi-modality. You can either use those modalities separately or combine them together. That's really the major point of the technique. So if you are looking at the literature, we start to have some papers showing that by using this kind of device, you can increase the number of procedures in the daily clinical practice, as shown in this American article published very recently in GVIR. But to my point of view, the greatest benefit of angio-CT comes with multi-modality, the combination of the different techniques. So if you take the example of an hospital, usually the CT scan is at one floor and the angio is at another floor, which means that if you want to use the two technologies for a single procedure, you will have to transfer the patient from one place to the other. And in terms of workflow, this is clearly not ideal. So you're not going to do it in the daily clinical practice. And with angio-CT, you get rid of this limitation. And clearly, it allows you to enter into a new dimension.
It's a small step for the radiologist. A giant leap for interventional oncology.
So first of all, combination of modalities. This is another view of the room in Strasbourg. And as you can see, we have the cone beam, which lies very close to the CT gantry, and we have the very wide screen giving us all the informations necessary. If you're looking at this short video, what you can see is that we can change very quickly from one angulation to the other. So you can combine lateral, oblique, AP, for example, and whenever we need it, we can, in less than 30 seconds, transfer the patient, the table, to the CT, and then have a CT acquisition. That's the beauty of the system. And it's not only about combining the modalities, it's also about making them communicating. If you look at this example, you can enhance the fluoroscopical images with the data from the CT scan, for example. So here is the native angio. Then you're going to work on the workstation, extracting the aorta and its branches. Here, the right renal artery, which was our main goal for the insertion of a balloon. Then you fuse the images based on anatomical landmarks, mostly bone. And at the end, you can enhance the fluoroscopy with the data set from CT images and create a roadmap-like imaging. And I will show you some examples during the next cases. So what can you do with that? I'm going to illustrate this with different organs, show you how we push the boundaries of what we were doing in interventional radiology since we have this system. So we got access to Angio-CT at the end of 2017, and I have to say that most of the procedure that I will show you right now, I would say that it's almost not feasible without Angio-CT, or at least not with the same level of quality and precision. So let's talk about liver first. You know that the combination of embolization and ablation is a possibility for HCC, mostly tumors between 3 to 5 centimeters. And again, having the precision allows you to increase and push the limits of what you can propose to the patient and to the clinicians. So here is the example of a young patient with a breast cancer, a 6.5 centimeter liver metastasis, which looks quite hypervascular on the enhanced CT scan. So of course, very challenging and beyond the guidelines of what we should propose. But just to demonstrate that having access to this equipment allows you to manage this patient. So in the same single session, one single general anesthesia, we start with the embolization using fluoro, of course. And here you will see we embolize that hypervascular tumor using gel foam. So as you are going to ablate immediately following embolization, you're not obliged to use particle, for example. So we start with the embolization, and then we switch to CT scan for the microwave ablation part of the procedure. So again, see how CT scan allows you to insert very precisely 3 microwave antenna, making sure you have access to a triangular configuration. We also performed in that case artificial ascites. As you can see, this is a little bit of fluid with contrast to push away the diaphragm from the liver, making sure we are not going to injure the diaphragm, which can create a diaphragmatic herniation in the months following the treatment. So maximal precision using CT scan. Of course, in that case, because of the size of the tumor, we had to reposition the antenna. And again, I'm repeating myself, but with CT scan, you have the precision to do that. And during the procedure, using this combination, what is feasible as well is to use what is called CT arteriography. So you have the catheter in the SMA here. You inject 20 mils of contrast. And if you do a CT acquisition 20 to 25 seconds after the injection through the catheter, you get a very nice portal face on the CT scan, and you can actually see the size of the necrosis here, huge necrosis. So you know exactly if you have to stop or if you have to reposition again the microwave antenna, and there is no limit of the contrast as you are only injecting 20 mils through the catheter, which means you can do 1, 2, 3, 4, 5, 6, 7 enhanced acquisition. So clearly allows you to increase the confidence in the treatment that you are proposing. Just to show you, that's the 6 months follow-up for that young patient. Complete destruction. If you look carefully at the images, it's almost a complete segmentectomy that you have performed using this combination. So it's feasible today. I'm not saying that it's easy and it's very straightforward. Also for the patient, it's not a small intervention. but still it's a valuable alternative, and we are proposing more and more those large ablations to our patients. Moving to kidney now. One very big challenge in kidney ablation is the treatment of very central tumors, because we have a lot of artery and veins here, which will induce what is called the cold sink effect. So the blood flow in those vessels will dissipate the cold or the heat, but mostly the cold, as we are using cryo for those central tumors, from the treatment area itself. So it will limit the size of ablation, and the centrality of a tumor is a known factor of incomplete ablation when you are targeting those challenging tumors. What we know from the literature is that if you clamp the artery, you are going to decrease the blood flow inside the kidney, and you are going to increase the size of the ablation just by stopping the blood flow inside the renal parenchyma. So because of that theory, and because we have access to this very precise equipment, we decided to try to combine arterial occlusion and ablation in a single session. So here is how it works. Look at this very central recurrence of RCC. If you are going to manage it with surgery, that's a radical nephrectomy. If you want to treat it with standalone cryoablation, it will probably not be effective, and in that case, it was a recurrence following initial standalone ablation. So the principle here is to insert, first of all, the cryoprobes, then insert a catheter in the renal artery, occlude the artery with a balloon, and then freeze the tumor. And because you have completely stopped the blood flow inside the kidney and inside the major vessel of the renal hilum, you are going to create a very large ice ball. So that's the example in the Angio-CT room. You can see positioning of a couple of cryoprobes, 6 here. Again, very precise insertion using CT guidance, protection of the colon, protection of the ureter using hydrodissection. This is how it looks like from outside. Then you switch to the angio part. So using a radial approach, usually we puncture the radial artery with ultrasound, and then we will insert a balloon inside the renal artery and occlude it, inflating the balloon. And of course, because you have access to CT scan and angio at the same time, you can do a CT scan with some contrast through the guiding catheter. So here is the balloon inflated. The guiding catheter is here. We can inject contrast and see the size of the ice ball and the size of necrosis using that technology. So it's almost a complete partial nephrectomy, but done percutaneously. So we are applying it more and more for central tumors. A typical example, central RCC abutting a major vein and artery inside the sinus of the kidney. If you are going to ablate this with standalone ablation, that's a tricky treatment because the ice will never expand in that location. So here we go, precise positioning of cryoprobes all around the tumor. Balloons insertion through the radial approach because the patient is prone, so the guiding catheter is in the renal artery. Then you put a small guide wire and inflate the balloon to occlude the artery. Then you can inject a little bit of contrast, making sure that the artery is completely occluded and there is no residual blood flow in the renal parenchyma. And this is how it looks like from outside. So CT scan at the back, this is the angio, the radial approach for the balloon, and the different cryoprobes inside the tumor. And then, of course, during the treatment, while you are freezing, you have access to CT scan. You can look at the growth of the ice ball. This is before freezing, and after the complete dual freeze protocol, look at the size of the ice ball completely expanding into the sinus of the kidney, something you would never see without occluding the artery, making sure you are covering the tumor with safety margins. So very high confidence in the quality of your treatment. Moving to bone, that's a growing field of interventional oncology. And speak first about ablation. Another example, that's a thyroid metastasis, single one, quite hypervascular. Here the goal is mostly to completely reduce the size of the tumor, at least trying to be as much complete as possible. Of course, it's challenging because you have the spinal canal just behind. You can see that the patient already got surgery just to decompress the nerve from the spinal canal. So here, the goal is, first of all, to get a catheter in the feeding arteries, embolize the tumor to decrease the vascularization, same goal. Decreasing the vascularization allows to increase the quality of ablation because there is less blood flow inside the tumor. Then you put the cryoprobes and you freeze and ablate the tumor. So with Angio-CT, you can do it again in one single intervention. First of all, embolization, as you can see here. We even use fusion with the previous CT scan, trying to put, not trying, but marking the entry points of the radicular artery feeding the tumors, which allows you to go for a faster catheterism. Then embolization using particles and coils in that case. And then you move to CT scan, having access to those very nice images on the wide screen. So here what we did, intradural injection of contrast just to identify the nerve. You can see the cryoprobes in position inside the tumor. And here, of course, the tricky case is not to ablate the nerve because then you would get a deficit. So we have a thermosensor in between the nerve and the tumor. And such precision, you can only achieve it using CT scan. Impossible to do it with cone beam. So again, having the precision of CT scan and the precision of angio in one single session allows you to freeze that tumor safely and provide a very effective treatment for the patient. Here is the ice ball during the treatment covering the tumor. That's the follow-up. Look at how the hyperfixation has completely gone using that treatment that was the 6 months PET-CT follow-up. Moving to soft tissue, it's also possible to go for ablation in the soft tissue, and we're more and more providing it, desmoid tumors, but also a soft tissue metastasis. That was a recurrence of breast cancer. Maximal radiation dose, the patient cannot be operated anymore. There is no other solution than ablation. But the problem is there's the internal thoracic artery in the middle of the tumor, and you know that because of the blood flow in that artery, there's a chance that some residual tumor will still be present following the ablation itself. Again, always the same thing because of the dissipation of the heat or cold, depending on the modality that you are using. So in that case, same session, one single treatment session. First of all, we catheterize the internal thoracic artery. The goal is to coil it, to occlude it. But what we can do is use the information of the planning CT scan, contour the tumor on the workstation, and then, as I said, you can do the fusion between the data from the CT scan and the fluoro. And this is how it looks like. Basically, you have the native fluoro and the fused fluoro with the data from the CT scan. And what you can see is exactly where the tumor is located, which means that you know exactly from which point to which point you have to coil. I'm not saying that this is mandatory for the treatment, but it increases the precision of what you're doing. Then you can go for ablation, and here it's challenging. It's near the heart, so precise insertion of a couple of cryoprobes, then very precise insertion of a 22-gauge needle in the pericardial fat, in the epicardial fat in front of the pericardium. You're not going inside the pericardium. And then you inject a little bit of fluid with contrast, just making sure where the dissection spreads. And as you can see, you are pushing away the heart from the tumor. And then during treatment, look how you can assess the size of the ice ball, very big ice ball, because that was an aggressive tumor that you can even see negative inside. And because we hydrodissect the heart, you can see it on sagittal, we're not freezing the pericardium. So maximum safety, but also we stay extremely aggressive towards that tumor. The goal being to be curative in this indication. And this is also a growing field. We switch from mostly palliative indication in interventional radiology to more and more curative indications, which means we have to increase the precision of what we are doing. And just to show you how fast it is to switch from the fluoro position for the embolization first to the CT position for the CT-guided cryoablation in the secondary part of the treatment, it takes less than 15 minutes. So this was the angio. Then if you do not need the C-arm anymore, you put it in parking position, as you can see here, and then you prepare the patient for the CT-guided part of the procedure. Moving to consolidation in bone. Again, that's very interesting because more and more cancer patients will suffer from skeletal-related events, fracture, pain, and we have the chance to treat those patients minimally invasively. So here, look at this very nasty fracture of the hip because of a large metastasis. The patient was really end stage, so not accessible to surgery, but still you want to mobilize the patient. He's lying in his bed. You have to do something in that case. So just to show you how the combination of fluoro and CT scan allowed us here to provide consolidation using screws and 30 mils of cement. So we had the chance to be successful in such a procedure because, again, you have access to fluoro and angio. So most of the intervention in that case is done under fluoroscopical guidance, insertion of a balloon kyphoplasty to make some space for the cement, avoiding any leakage inside the joint, then insertion of wire, advancing the screw over the wire, injecting cement. This is done under fluoro, but at any time during the intervention, I can acquire CT images, make sure, for example, that the wire is perfectly in position inside the iliac wing and above the acetabulum, making sure I'm not going too posterior, close to the sciatic nerve, because this is not always easy to assess precisely with angio. And it's no problem because you can switch anytime you want between fluoro and CT scan as shown on that video. You can do it 10 times, 15 times, 30 times. There is no limitation. So you do not hesitate to acquire CT images whenever you need it. And just to show you how much you can push things, this is an intervention I was thinking about it, but I would never have dreamed about performing it before I got access to Angio-CT. Here is a pathological fracture of C2. The patient was not accessible to surgery again, end-stage disease in a cancer patient. So cementoplasty in that case will not be sufficient because of the different loads which are applied in that location. So you need to add a screw to cement, but it's challenging to do it percutaneously because you have the pharynx, you have the vessels. So what you're doing here is use the precision of CT scan to do the hydrodissection of the jugulocarotidal and prevertebral space, again using fluid and a little bit of contrast to increase the identification of the fluid. And then through these hydrodissected spaces, you insert the guide wire for cement and screw insertion. And here is how it looks like from outside. So it's really minimally invasive. And that's at the end, the results, perfect insertion of the screw in the endotoid process with a cement injection. Why were we successful? Because we can access anytime AP, lateral, and CT. And look how CT helps to make sure, for example, that the guide wire goes through the previously hydrodissected spaces without injuring the pharynx or the vessels. You have maximal precision. And just to show you how it looks like during the intervention, so I use mostly AP and lateral, but similarly to the other case, whenever needed, you can switch to CT scan, making sure in 3 dimensions that everything is correct. So my key message is that if Neymar ever breaks his back again, there is no reason that you cannot fix the fracture immediately and then win the World Cup. So as a conclusion, I hope I have convinced you that the Angio-CT system, first of all, allows you to cover 99.9% of what you can do in interventional radiology because you have access to CT, angio, and ultrasound if needed. But again, for you and for the benefit of the patient in Brazil, you will be able to expand the indication of what you are doing. That means performing new interventions, not only for oncology, but you can imagine that for trauma or for any other disease, there's a benefit of using this technology, and many things still have to be done in that field, and I hope you will participate to the improvement of the technology in the very next future. Thank you very much.
Mais ainda no futuro próximo. Muito obrigado. Wow, all that technology in favor of science. What do you think about that, Dr. Abeth? It's fascinating. In those 20 minutes, he gave us a great idea and explained why we believe this is the future of interventionist radiology. So 2 different technologies, 2 equipment, diverse technologies with advantages that on to each other. Currently done on different days, and now we can bring these 2 technologies together in one room. It's much more comfortable for patients, it's much more comfortable for physicians, and you can expand the indications. So in oncology, complex tumors that nowadays are very hard to treat with the current technology. And by combining these technologies at the same time, we're able to treat tumors in areas that are different to reach, bulk tumors, and there's a lot of things that have to be discovered. It's a new technology, and in this new era, I believe that we will have a paradigm shift and have new treatment diagrams or flows. And the precision, yeah, you can see the tumors very close to nervous structures, and it's precise. You have fluoroscopy, that's part of the angiography, and you can combine that immediately with a CT. And in immediate control of treatment, through a CT, you can see if the treatment was well done, if the tumor was completely destroyed. So you said that well. Two things add on to this equipment: safety and effectiveness.